Okay. Other drugs that weaken the cell wall. So we talked just about the penicillins, right? That was the first group that weaken the cell wall. That's all we've talked about are the penicillins and some of these penicillin combos. Other drugs that weaken the cell wall include the cephalosporins, carbapenems, vancomycin, telavancin, atrionam, and fosfomycin. Okay? And if you remember, the cephalosporins had multiple generations, right? So there's a lot of drugs that fall under that big cephalosporin label. Okay? The cephalosporins are frequently second-line choices when penicillins are not possible, okay, or not available, or not working. Okay, the cephalosporins are frequently a second-line choice. They still belong to this larger beta-lactam family. They are similar to penicillin in structure, particularly with that beta-lactam ring. Okay. They are bactericidal. They kill bacteria through this mechanism of weakening cell wall synthesis. And then we talked last time about penicillins are most effective on bacteria that are doing what? Actively dividing, right. Because in the process of cell wall synthesis is when weakening the cell wall is most effective at killing them. Okay? Cephalosporins are very similar in that vein. Big differences between cephalosporins and penicillins. All the penicillins can be given orally. Some of the cephalosporins must be given parenterally. Okay? But like the penicillins, the cephalosporins have low toxicity. Okay? And they have a couple more possible adverse reactions compared to the penicillins, but the one that they do share is allergenicity. Okay? And it's not always true that if you have a penicillin allergy that you will have also an allergy to cephalosporin. Okay? But sometimes there is some cross allergenicity. So cephalosporins have actions similar to penicillin, and in fact, they also bind to similar targets. So the targets on the bacteria that penicillin binds to, we refer to as penicillin binding proteins, and cephalosporins bind to those same proteins. So not only will the cephalosporins also be vulnerable to the beta-lactamase, okay, that same enzyme that can digest penicillins, but bacteria that have altered penicillin binding proteins will also be resistant to a certain extent to some of the cephalosporins. Okay. And the cephalosporins, like penicillins, most effective against cells that are undergoing active growth and division. There are resistant organisms that can produce beta-lactamases, as we mentioned, and then the different generations of cephalosporins, their primary differences are their sensitivity to the beta-lactamase. So the first generation cephalosporins really are highly sensitive to beta-lactamase. Okay? So there's more resistant organisms to those first generation drugs. The second generation drugs are less sensitive, and the third, fourth, and fifth generations are predominantly insensitive or resistant to those enzymes. Okay. But it's likely that the algorithm for treatment is going to still be a first generation is going to be first choice. If it's not responsive, then you might choose a second or third or fourth generation. Okay. You don't in antibiotic prescribing. It is not encouraged to reach for the strongest antibiotic all the time first. Okay. Because if that infection develops resistance against that very strong antibiotic, you have nowhere to go. Make sense? So we have 5 generations of cephalosporins. We have some stereotypic drugs. Yes, cefoxitin. Thank you. Yes, second generation. Not a penicillin. That was the drug that was on that penicillin list. So we've got some, we have some typical drug examples of every generation. Okay, so 5 generations with increasing, or I should say decreasing sensitivity to those beta-lactamase enzymes. The cephalosporins do have some drug interactions that are important to understand and some adverse reactions beyond what we see with penicillins that are important to understand. Probenecid, which is a acid-reducing drug, delays renal excretion of cephalosporins. So what effect will that have on cephalosporin levels in the blood? It will increase, right? So if probenecid delays renal excretion, then cephalosporin levels will increase. Okay? And since cephalosporin has a relatively low toxicity, that's not too concerning. However, if you have vulnerability to some of its adverse effects, that may be a problem. Cephalosporins interact negatively with alcohol. So cephalosporins can block the metabolism of alcohol and cause alcohol intolerance or alcohol poisoning. So it is contraindicated to mix alcohol and when someone's on a cephalosporin. Drugs that promote bleeding. So cephalosporin, one of its adverse effects beyond allergy is a tendency to cause bleeding. Okay? And so taking other drugs like heparin or Coumadin or aspirin that also increase bleeding can increase risk for excessive bleeding or hemorrhage. And then combining calcium supplements with certain cephalosporins like ceftriaxone can produce these highly toxic precipitates. So the drug binds the calcium and produces this precipitate that is highly toxic to the body. So when people are on that drug, we want to discontinue their calcium supplements for that duration. Yes, ma'am. Ceftriaxone is, not sure what generation that is, but it's not going to be for all of them, but it may be for all of that generation. I'm not sure. Yeah. It's a third generation. So definitely for that drug combination, but I will check on whether it expands to that entire generation. Okay. Yes, ma'am. It would matter. It would matter. It would have to be extremely high consumption rates, and it's likely that you would recommend people not take milk or dairy with the drug, right, at the same time. But it's more of an issue with calcium supplementation because the calcium levels are so much higher. Yeah. No, there are drugs like antabuse and things like that that cause intense like emetic responses when you consume alcohol, but that's not. Yeah. Yeah. Yes, ma'am. A what? I'm sorry. If you have high calcium levels, an indicator of cancer. No. Yeah. Okay. That's a very good question. I don't know the answer to. If you naturally have high calcium levels, you mean above normal limits? Above normal limits. Yeah, I don't know. I don't know. It's a good question. I'm not aware of too many of that being a naturally occurring difference, right? Calcium is pretty tightly controlled by the body, so being on the high end of normal, but being above normal as you know, that would probably reflect some sort of pathology, maybe cancer, but I don't know. So, in addition to bleeding, thrombophlebitis, which thrombophlebitis is the development of clots within veins that causes intense inflammatory reactions. Okay. So cephalosporins, because they are given parenterally, so they're going to be given with an IV, the thrombophlebitis is a complication of basically intravenous therapy, and so giving it cephalosporin intravenously, there's a slightly higher risk of thrombophlebitis. Okay. So among the cephalosporins, in terms of therapeutic uses, the first generation is most active against gram-positive organisms, and it's widely used as a prophylaxis against infections with patients undergoing surgeries. But it's not as frequently used for active infections. Okay, so it's frequently used prophylactically, not so much for active infections. Second generation drugs tend to have a narrow scope of applications, so we frequently use oral versions of these drugs like cefuroxime for otitis, which are ear infections, sinusitis, and upper respiratory infections that are bacterial. Okay. And then third generation are preferred therapies for several active infections. Okay. They're highly active against gram-negative organisms, which is very handy because gram-negatives are highly pathogenic. They are able to penetrate the cerebrospinal fluid, penetrate the blood-brain barrier in order to enter cerebrospinal fluid. So they can treat infections that are on the other side of the blood-brain barrier. But they shouldn't be drugs that we go to first, right? So they're frequently alternatives to other drugs. Okay? If you've had a chance to look over the drugs of choice by infection, so that handout that I posted of different infections and what drugs we tend to go to first, the cephalosporins are frequently in that alternative category. Okay? So we have lots of drugs that are first-line choices, and then the cephalosporins are frequently second line choices or alternative choices. Okay. Yes, ma'am. It's the second generations, with that drug being a little more common. Yeah, you're welcome. Okay. Now, for the fourth generation cephalosporins, they're commonly used to treat healthcare and hospital-associated pneumonias. So these are infections that people don't have before they enter the hospital, and then they acquire in the hospital. And then hospital or healthcare-associated pneumonias are frequently, they're unfortunately a very frequent infection, and it's particularly common in patients who are unconscious or patients that are restricted to being in bed, okay, or immobilized. The Pseudomonas organisms are a common cause of this pneumonia, and so those fourth generation cephalosporins are very effective against those Pseudomonas organisms. And then the fifth generation cephalosporins are very handy for treatment with, against MRSA, the methicillin-resistant Staph aureus. So those are the staph infections. Again, frequently hospital-acquired, so frequently people will get infected with MRSA in the hospital, although there are community-acquired versions of MRSA. Okay? And the community-acquired versions of MRSA are much more problematic than the hospital-acquired ones. Hospital-acquired MRSA tends to be a particular strain of Staph aureus, that is not as virulent. Okay? It's not as strong or hardy of a bacteria, because it's a bacteria that tends to do well on people who are ill, okay? And who already have lots of layers of susceptibility. Okay? So treating MRSA that's hospital-acquired, while difficult, is not as problematic as treating MRSA that's acquired in the community. Okay? Because MRSA that's acquired in the community is competing well with a lot of other bacteria. Okay? So that's a much hardier version of MRSA. But MRSA that is community acquired started with someone who had hospital-acquired MRSA entering the community. Okay? And so that MRSA evolved within the community to be able to be spread from person to person. When it comes to the hospital-acquired pneumonias, it'll be a first-line thing. So they'll find that you've developed a pneumonia. We're on, let's say, on a mechanical ventilation. That's a very common sequence of events. You're on mechanical ventilation, and then you develop a pneumonia. You would go straight to that fourth-generation cephalosporin. When it comes to MRSA, you've already been treated. You have an infection. You've already been treated, right? It's not responding to that treatment, and so the conclusion is that it's a Staph aureus that is resistant to conventional treatment, and now it's diagnosed as MRSA. Yeah.